Hello, my name is Jack Charlier, and I am the Executive Director of TASC's Center for Health and Justice. I am very pleased and excited to welcome you today to the JCOIN Speaker Series on Deflection, leveraging police and first responders to create new pathways to treatment and recovery. Along with me today for the webinar will be Jessica Halsey, who is the founder of Addiction Policy Forum. You'll get a chance to hear more from her later. I want to just comment very quickly on a few things, and then we're going to get going right into this and introduce Dr. Tisha Wiley from NIDA, who is the project lead for JCOIN. So a few things. First of all, we'd like you today to participate. We want you to be engaged in the presentation and with our speakers. This is a huge part of what we want, not just listening, but also engaging, asking questions, putting comments. And to do that today, we're going to ask that you use the Q&A, not the chat box. So use the Q&A. The chat box is disabled. The Q&A is a better way for us to communicate, keep track of everything that's coming in. So use the Q&A at the bottom middle of your Zoom screen. Do not use the chat box. For today's presentation, we're going to introduce everybody. And as I do that, I'll read a very brief bio on them. They'll speak, and then we'll go on to the next person. So you'll get to learn about everybody who is on the screen as we go through the order of the speakers today. Finally, as I said, welcome to the JCOIN Speaker Series. I introduced myself already, but what I didn't say is myself, along with Jessica, TASC, along with APF, are partners in the DSEC, which is the Dissemination and Stakeholder Engagement Core part of JCOIN. And our responsibility is to make sure that you, the practitioners who are on this webinar, this first ever Deflection webinar today, are able to have your information come into us, have our researchers look at it, and go back out to you and have that dialogue and exchange going on. So it's very practical and useful to you in the field. And so I want to recognize Jessica and APF, as well as TASC and the staff at TASC that together form the DSEC, again, the Dissemination and Stakeholder Engagement Core. With that said, let's go ahead and get started. Again, welcome for those of you who have just joined us, maybe coming in a few minutes late, but let's go and get started. I want to introduce Dr. Tisha Wiley. Dr. Wiley is the Chief of the Services Research Branch and Associate Director for Criminal Justice at the National Institute on Drug Abuse, of course, NIDA, part of the National Institutes of Health, NIH. Dr. Wiley leads, of course, the Justice Community Opioid Innovation Network, JCOIN, which is a 5-year and $170 million plus initiative focused on transforming responses to the opioid crisis in the justice system. So without any delay, Dr. Wiley, over to you.
Great, thank you, Jack, and thank you everyone for joining. I really want to thank TASC and APF for putting this together, and I really want to thank our panelists today too for joining and sharing their research. I'm really excited to be here today. This is a webinar series that the DSEC has organized for JCOIN. We've done these on a number of topics, but I'm really excited to have this opportunity today to do a webinar on deflection. For those of you that aren't familiar with JCOIN, one thing that I just want to share is that we have a vision in JCOIN that really drives all the things that we do. And that's the idea that everyone who has a substance use disorder that comes into contact with the justice system should have access to effective care. And that's whether they're detained or in the community. And much of what we do in JCOIN really focuses on what happens in the back end of the system. So what happens once people have been incarcerated and returned to the community. But I'm really excited for this webinar today and for this collaboration with TASC and APF to discuss deflection, because I think we can do so much more if we keep people from getting that deep into the justice system in the first place. And deflection as a movement is something that has grown out of community level collaborations among police, among treatment providers, and the communities that they serve. And so we think this is a really important time to be having this conversation. These are conversations that are happening in communities all around the country, and they tie into the larger conversations about how law enforcement responds to people who use drugs or have mental health issues. And Jack is certainly the expert here, but deflection is a systems change strategy. It's really been something that's been gaining momentum over the last 5 to 7 years and growing as a field. And I think what's interesting about it is this explicit emphasis on community empowerment and allowing community members to be active partners and developers of solutions for their own communities. So as Jack mentioned, this is our first JCOIN event focused on deflection. But what I'm excited about is this is not going to be the end of it. So we're going to take this content, and that's going to provide the foundation for our e-course that will be developed in partnership with the Police Treatment and Community Collaborative, or PTAC. And so others you'll be able, if that interests you, you'll have the opportunity to engage with that e-course, and we're working on getting that information out there. JCOIN as an initiative, one of the things that's really important across all the different things that we do is about building relationships and partnerships across different sectors and providing evidence-based solutions and data on things. So deflection as a new and growing area, I think there's so many opportunities to make contributions and advance our vision of ensuring that every person who has a substance use disorder that's coming into contact with the justice system is getting access to evidence-based services. And so I think it's really exciting that deflection is a promise to helping ensure that access to evidence-based care doesn't require someone to go deep into the justice system. And I think that's ultimately good for everyone, and it will lead to safer, healthier communities. So deflection really reframes the relationship between police and first responders with their communities. So it turns those early encounters into opportunities to access care, to improve well-being, and to break cycles of drugs and crime. And as I just said earlier, I think that's really good for everyone. If we treat people in the community rather than requiring that they go to jail to access treatment, that's also going to help us address many longstanding racial and social inequalities in our communities. I think we really, and this is a view that's shared by our director of NIDA, Dr. Nora Volkov, we should stop criminalizing the disease of addiction. And I think deflection is a powerful tool that's not yet been used to its full potential to contribute to safer, healthier communities. So with that, I'm going to turn to our outstanding speakers because they have lots of great data and examples to share with you. And thank you again for joining us. And I look forward to hearing from our speakers. So I'm going to turn it back over to you, Jack.
Thank you, Dr. Wiley. I appreciate an excellent open comment. It's a kickoff what is going to be an outstanding webinar on, again, leveraging police and first responders to create new pathways to treatment and recovery through deflection. I now want to bring up our first speaker, Dr. Bruce Taylor. He'll do an introduction, overview, methodology, and survey design of the first ever report done. It was a national survey to assess first responder deflection programs in response to the opioid crisis in the United States, done by United States Department of Justice, Bureau of Justice Assistance. Dr. Taylor is a senior fellow at NORC at the University of Chicago and a criminologist studying the intersection areas of violence, health, and justice. He has 25 years of experience in applied research, surveys, and randomized controlled trials, but he has only 5 minutes right now to speak. So Dr. Taylor, over to you.
All right, thank you, Jack. Appreciate it. So we're going to talk about our national survey to assess first responder deflection programs in response to the opioid crisis. Hopefully you can see my slides. I'd like to think you can. Okay, good, excellent. So to our knowledge, this is one of the first nationally federally funded organizational level surveys specific to law enforcement led diversion and first responder deflection programs built on the 5 pathways of deflection that cover substance abuse disorders and opioid use disorder. We surveyed not only law enforcement, but also fire departments and EMS who was serving those with OUD and other substance use disorders. And this was, as was mentioned a little bit earlier, a collaboration with BJA, IAR, with the task group that Jack's with, IACP, and then also NORC, who did the survey in terms of all of the development, dissemination, analysis, and reporting the survey was a collaboration of these groups. So as folks know here, you know, the deflection programs are a response to the opioid sort of crisis. And as folks know, there's been a dramatic increase in the number of opioid overdose deaths, a dramatic expansion of synthetic narcotics, and more than 2/3 of all overdose deaths are related to opioids. So focusing on opioids, which our project did, was we thought made a lot of sense. And we see the sort of deflection programs as a direct response to these forces and as sort of a third wave of police beyond enforcement and arrest or doing nothing to address this problem. And people are probably familiar with this, just looking at the basic sort of extent of opioid deaths. And here, there's quite a lot of them. And what we're just going to simply present is just that in this period here is where we start seeing the deflection programs where there's an increase. I'll just bring up this next slide. Sort of around here, we start in the early days of the 80s, there were programs, and then they started popping up more in by 2015, 2016, you start seeing a lot more programs, and that 2017-18 era kind of lines up pretty well here with the sort of the rise in the synthetic opioid overdose deaths. So there's quite a need for these programs. And I'm just going to say a quick word about the survey method so people understand some of the strengths of the study and then also some limitations. We identified 880 organizations that were thought to operate first responder deflection programs. So the general idea was to try to get every sort of first responder deflection program into the study. It wasn't a study about the prevalence of these programs, so we didn't do a survey of all law enforcement or all first responder organizations. We focused on those who were known to be doing the program or could be reasonably expected to be doing the program. And now in terms of our response rate, we reached just about 50% for completed surveys. And then when we factor in that folks who did sort of most of the survey, but not all of the survey, the response rate jumps up a little bit to 62.4%. We collected the data, importantly, from January to September 2020. So this overlapped pretty strongly, of course, with the COVID-19 pandemic, which made it difficult for a lot of the first responder organizations to do the survey, essentially, because they're responding to the, especially at that point, this was all new. And what we saw was that normally when we do these kind of surveys, we can often get considerably higher response rates. But in this case, there were few staff to sort of do these surveys. Sort of the urgency and the immenseness of the pandemic just, in some ways may have reduced, at least at that time, the criticality of the survey because of the whole new problems that were going on. So it's probably fair to say that if, the pandemic had not occurred, which people say for a lot of things, we probably would have had a better participation rate. But we're really still proud of what we were able to achieve and really thank the organizations who did manage to complete the survey. And it was a fairly detailed survey that often really could take upwards of about 30, 45 minutes in some cases, and depending on what information they had to gather, it could be longer. So it was in some cases, when you're dealing with a pandemic, a heavy lift. So we understood that some organizations were just not going to be able to respond to the survey. And a quick thing, as I'll pass it off to Dr. Ross next to talk about the survey, is that these are aggregate level survey questions. So these are at the sort of agency level where we're asking them sort of how many sort of personnel they may have working on deflection programs, as opposed to asking about any client level data. And we used multiple modes for the survey to try to get the best response rate. So the survey itself was on a web format, a secure format, but we also phoned agencies and sent paper versions of the survey if they preferred to do it that way. Most people did prefer to do almost not everyone, but like 95% did the survey online. And in terms of the actual development of the survey, it was a rather extensive process that we undertook. Detailed literature reviews, looking at prior surveys. We had an expert panel that we worked with in terms of putting this together. Over 20 experts were brought together for multiple meetings to go over this. We also did cognitive testing of the instrument to make sure agencies would be able to clearly understand the survey and fill it out. And as I mentioned, it was an extensive data collection period of 9 months. And not only, the other thing I think that's real important, I'll close on this, is that we used multiple methods of both sort of postage and emails and things like that. We didn't see a difference in our response rates based upon sort of where folks were in the modality that was used to reach them. So that was kind of reassuring. The other thing I would mention too is that to our knowledge, this is the most comprehensive list together, and we are kind of feel good that in terms of how people respond to the survey, there were not differences. So with that, I'll pass it on to Dr. Ross.
Thank you very much, Dr. Taylor. And actually, before we go over to Dr. Ross, I just want to quickly read his bio. Thank you for that. And thanks to our partners at Department of Justice, Bureau of Justice Assistance again, give them a quick shout out. So let me now quickly introduce Dr. Ross, who will speak to the national survey that you just heard about, the makeup, the leadership of deflection programs, the nature of partnerships. Partnerships are central to deflection. Dr. Ross is the Director of Research and Evaluation for TASC Center for Health and Justice. And in that role, he leads internal and external projects that collectively advance knowledge regarding evidence-based practices. And most critically for today, he is the TASC internal lead for JCOIN. And I want to commend him and his staff, the work they've done on bringing this webinar to life today and the subsequent, as you heard Dr. Wiley said, the subsequent deflection e-course that we will all invite you to take and share with others that will be forthcoming. Dr. Ross, over to you.
Thanks, Jack. Thank you, Bruce, for setting this up. Bruce has kind of established the grounds for doing this. So let's go through some of the key, and my screen just froze. Hold on. Let's try that again. Let me try this again. It froze. I'm gonna. Okay, thank you. Okay, so let's look at some of the key findings from this. As Bruce said, with the advent of the third wave of the opioid crisis and the rise of deflection programs, it's no surprise that most of these programs have been initiated and are led by law enforcement agencies, police and sheriffs mainly, with some from other agencies and many joint operations. And as he said, again, this was largely a response, as he showed on the graphs, to the third wave of the opioid crisis. So it's no surprise, as you look at the bars here on the bottom, that opioid overdoses, whether they're fatal or non-fatal, and significant increases in opioid use were proximate causes of quarters of the programs we've identified that have gotten underway. There's been a lot of discussion lately about the proper role of police, who should be involved in calls and responses to calls involving nonviolent crime, drug use, addiction, et cetera. As it turns out, deflection programs are really at the lead on this in terms of bringing co-responders to the table. Co-responders are those who are not traditional first responders, case managers, peer recovery counselors, clinical SUD professionals. And in fact, what we've learned is that more than half, close to 60% of deflection programs work with these co-responders on a number of levels, including the initial contact. And the most prolific, most common profession employing that is the peer support and recovery specialists, who are an important element of deflection programs. Deflection programs, what makes them unique is that they have a personal introduction. There is a personal introduction, what we call a warm handoff, that is made between the deflecting agency, usually the first responder entity, and the treatment or case manager side. But the warm handoff is more than just a literal transition or handoff of one person to another. It's a critical piece of the care coordination and case management. And in fact, programs that are well partnered in deflection use the warm handoff in a lot of ways to build relationships and do whatever they can to expedite and facilitate the engagement of those being deflected. So providing transportation services, for example, to that initial meeting, doing anything that's possible really to facilitate that engagement for everybody involved, not the least of whom is the client. Another thing that's very important is what we call feedback loops. It's not just that the first responder agency hands the person over and then goes away. Feedback loops are implemented into many deflection programs as a best practice, so that those who have done the deflecting can keep track. They want to know if the treatment and the care coordination has taken place and what the disposition of the client is. Remember, most of the calls that first responders get involve repeated calls, where they often involving the same people over and over, where they really can't do much without a deflection option. So they want to see that the investment of this in this effort has borne fruit. So these are very important elements. The handoff is much more than just a simple transaction or transition of people. Let's talk about some findings that relate to what the kinds of treatment and services that are being provided, facilitated by deflection programs. One, about 90% of them provide some sort of SUD treatment. And the most common service provided of that nature is medication-assisted treatment, MOUD. That's about 3/4 of programs are doing that. That's important, of course, given the scope and the demands of SUD cases and needs. And many programs provide multiple MAT programs. Another key element, and we talked about this in the warm handoff and in the co-responder discussion, is the role of recovery support specialists. Roughly 80% of programs we found are using recovery support specialists in both in the initial outreach, either in the co-responder model, in the warm handoff, and or in the longer term engagement in deflection programs. And a lot of the recovery support and peer specialists are people with lived experience, people who are credible messengers to the people they're working with and treating, to not only to build relationship, but to enhance treatment and the long-term relationship and recovery. And those are very, very important elements throughout the process of deflection. This last bullet, I'm a policy wonk, so this is a particular interest to me. There are 38 states and the District of Columbia that have expanded Medicaid under the Affordable Care Act since that law went into effect. And those states comprise about 90% of the deflection programs of which we're aware. That is not a coincidence. Roughly half, slightly more than half of programs use public insurance to facilitate treatment. And because deflection, again, is a community-centered, locally based enterprise, most programs require and use and rely on local funding to start, expand, and maintain their programs. So the more, the wider the array of funding options, including expanded Medicaid access, the greater the opportunity they're going to have to actually do the work they want to do and thrive. So there is a very significant connection between the presence, we believe, of deflection programs and the states in which they exist that are Medicaid expanded. We've talked, and we will talk a lot about partnerships in deflection. Partnerships are more than just people sitting at a table periodically and working things out. We're talking about well-integrated, well-run, fully integrated partnerships. And the more partnerships, the more partners in which these involved in these programs, typically the better. Most of the programs we see have between 2 and 5 partners who are fully engaged in client outcome related work. We've also found that programs that have a kind of a professional or a corporate operation with a day-to-day program coordinator, something like a chief operating officer, to run the day-to-day affairs of the program tend to be very useful, and they tend to do a very good job of integrating stakeholders well. All of the programs we've identified have at least annual meetings of stakeholders, but most have far more frequent than that, and that's certainly a best practice of partnership. There are a couple of gaps we've identified through the survey. These are not surprises given that this is a very quickly expanding sector. One is that there's a lack of formal training curricula in a lot of these programs. Only about 1/3 we've identified have formal training programs. The ones that do tend to provide naloxone administration training, crisis intervention management training, important things. We certainly think that this is of much greater need to expand. This is something JCOIN and other entities are very much involved in. And some other areas of training that really need to be integrated include the neuroscience of addiction, motivational interviewing, and other factors that aren't part really of traditional police training. And another area, and Jessica Riker will get into this shortly, so I don't want to take too much time on it, but evaluation is an important element. As a sector grows rapidly as this one is, doing quality assessment, doing independent evaluation of program outcome performance and how to retool and refine is necessary, and it's a critical best practice. Speaking again to partnerships, this is an area again where partnerships can be very useful in getting this kind of work done. Partnerships with academic institutions, with independent research agencies that do the data analysis and collection. Very critical here, but she's going to talk more about that. She's definitely the expert on that. Just some final thoughts on this that really align to what Jack and Dr. Wiley said at the beginning. There is a lot of discussion in the public sphere. We've all heard it in the last year or so about what is the proper relationship of the police with respect to the communities they serve. And what do we need to do with the resources that are involved in public use? We think deflection is right at the point of that reform, because essentially, as Dr. Wiley mentioned, what we're doing is we're reframing the relationship between the police and the community. We're getting people, we're protecting and preventing people from going into the justice system by having community-based services that give them opportunities to get recovered and to thrive with their families, within their communities, with their friends, with their familiar settings. And of course, in doing so, we're addressing people who have fallen through the cracks of the system, who are disproportionately directed into the justice system or disproportionately not getting the treatment and services that they would not otherwise need or get without the presence of deflection programs. And that, of course, addresses people who have been left out of the system as a result of racial or social inequities. Altogether, those factors reduce the size of the justice system. They reduce the budgets of the justice system, and they refocus our budgets, whether they're in the justice system or the social services system, toward those who are in most in need. I put a link here to the survey we did if you want more information on that, and I'm happy to handle any questions when we get around to them. Thank you.
Now I'm going to turn it over to another colleague, Jessica Reichard, who will do an overview of her work in research and analysis and evaluation in deflection. She is one of the leading researchers in the field of deflection in the United States, and I never want to forget to say that, and a very trusted colleague. Jessica Reichard is also the manager of the Center for Justice Research and Evaluation at the Illinois Criminal Justice Information Authority, where she directs research and evaluation projects. Ms. Reichard has published more than 100 articles and reports, including in peer-reviewed journals. Jessica, I'm going to turn it over to you right now.
Okay, thank you. I'm going to share my screen. Okay, so I'm going to talk about evaluation findings, as well as briefly about some legislative support. Illinois is sort of leading that effort, and I'll talk briefly about that. Just a brief intro, in case you don't know my agency, it's the Illinois Criminal Justice Information Authority, or ICJA, and we're a state agency that administers federal and state grants for criminal justice, violence prevention, and victim services. And then we also have a research unit. Obviously, I'm in that unit. Here's information on the funding for the work that I will be discussing. So I'm going to very briefly summarize what we know from prior evaluations from others, and then offer detail on 2 completed evaluations of deflection programs in Illinois that I've led, and then provide a summary of upcoming evaluation that I'm involved in. So the field of deflection has grown quickly in recent years. So, that's been said. So there's been limited evaluation. To date, most of the program participant descriptions, most of the research has been program participant descriptions or qualitative data. There was a recent review of the literature on deflection by Lindquist Grants and colleagues, which I'm just sharing briefly here. They found 31 studies on deflection programs that had quantitative and qualitative analysis. There were 24 US programs that were evaluated, 16 used a comparison group, and 3 used a randomized control trial with a control group. The majorities of the studies collectively found reduced recidivism, and 45% of those programs evaluated reduced substance use. So now I'm going to share some of my own research. I'm going to focus on evaluations of 2 programs in Illinois. Both use self-referral pathway, in which individuals can walk into a participating police department and request and receive treatment. They get a warm hand up without any fear of arrest. For this first evaluation is a program called Safe Passage. The main research question was, how was the program implemented? And what did stakeholders and clients think of the program? So again, self-referral pathway, it's in 2 rural counties in northwestern Illinois, and it started in 2015. So one of the earliest programs to start. We did a process evaluation. So we used client treatment provider interview, client and treatment provider interviews, stakeholder focus groups, and a police survey. We also looked at their administrative intake data. In their first year, the program deflected 83 people to treatment, and over half were male. The average age was 33. They all had issues with opioid use disorder. 83 had no insurance at intake, and 83%, sorry, and 83% also had a prior arrest. And I wanted to show this map because this program is, again, in a rural area, so there was limited treatment available to people in the community, and this map shows the distances that the program would travel to get people into different treatment providers. So they were really trying to overcome that barrier of limited treatment in a rural area. So based on the data, we found clients were saying that they were a little nervous and scared to approach the police, but obviously all of them did. They all had a positive experience and all really supported expanding the program and would recommend it to others. And the police survey, we had a lot of responses. We had 79. So it was almost all the police in the departments. 86% were supportive. Majority said that it was effective, and also said the community was supportive. And then when we held the focus groups with stakeholders, there was just a broad group of stakeholders engaged in the program and supported it. They also said that the community was supportive of the program. And then we talked to the treatment providers, and they all said that the program builds relationships between treatment, police, and the community. They did recommend some more community awareness about the program and some more police training. So we did have some recommendations that came out, and it was interesting to see when John just spoke about some of the findings, kind of mirrored what I was finding in this evaluation, that a coordinator is very beneficial, that aftercare support is needed, that officer training is important, and then enhancing the community awareness of the program. So what was great is that many of these things were implemented after my evaluation. So they did hire a coordinator, recovery specialist person who does assist people with aftercare when they come back to the community. So that's really great to see them taking those recommendations. So this report was published in 2017, and it can be found on our website. So now I'm going to share findings from the other evaluation. This program is called A Way Out. The main research question here was, to what extent did arrest outcomes differ for those who were referred to substance use disorder treatment through A Way Out compared to those who were referred to treatment by other means? So the Way Out program, again, self-referral pathway. This time it was in Lake County, which is a suburb, the suburbs of Chicago. So more of an urban program. It started in 2016, and to date, it's helped more than 800 people. I got the number 835 just a couple weeks ago. It's their total. So they've been in operation for 5 years and have helped so many people. So this kind of shows how we did the evaluation. We used quasi-experimental design, which means we created this comparison group. We compared by referral source, so those who were referred to treatment by a way out, or those who were referred to treatment in other ways, including the courts, healthcare providers, family members, or they just self-referred, went directly to the treatment provider themselves. So we pulled individual electronic treatment records on site from the treatment provider's case management system, and we also linked that to arrest records, which was the outcome we were looking at. And we looked at clients who were served from the start of the program in June of 2016 until July 2018, so a couple years. So we found there were no differences in these arrest outcomes, whether it's any or the average number of arrests, the average number of misdemeanor arrests, and any or average number of felony arrests. So there really wasn't a difference between them going through a way out or going a different way in terms of arrests later on. The only difference that we did find that was just statistically significant was that a larger portion of the way out deflection people had, whether they had any post-treatment misdemeanor arrests. So there are 29% that had a misdemeanor arrest after going through the program. And then that was actually just slightly higher than the criminal justice system, which was 27%. But then the family arrest outcomes, family referrals were 17%, self-referrals were 18%, and health providers was 19%. So only a slightly different difference there. So clients had a high completion rate of 72%. So that really suggests a potential reduction of future substance misuse and related crime. Some had no prior treatment, and 38% had no insurance, which was higher than the other referral types. So I think police can really be an early access point for treatment for people in the community. They may not know how to go about getting into treatment. Also, maybe they're concerned about not having insurance, not knowing how to cover it. So these are all good things. We also know accessing treatment once gives them the knowledge to access it again in the future if they need it. So the main takeaways that the arrest outcomes were similar, that deflection program offers another access point to treatment, can help improve public health and safety, and it appears to be a promising model. So this article was published in May of this year, and it is also available on our website. So now I'm going to share the work on a current evaluation that's in progress. This time the research question was, how does a county with a deflection program compare to similar counties without a deflection program on key outcomes? So we look at arrest, overdose, and treatment admissions. So the National Institute of Justice put out a solicitation for research grants to specifically study deflection, which is amazing to see them putting resources into that. RAND was awarded the grant, and it's in collaboration with my agency, ICEJA, as well as TASC. And the project started in January of 2020, and we're looking at multiple deflection sites in the country. So the first phase of the project, and there's two phases. The first was to do case studies, which was interviews with stakeholders in 6 sites across the country, including in Illinois, Massachusetts, Indiana, Pennsylvania, Wisconsin, and Washington. So this phase was important to be able to understand different programs and then guide the selection of 2 sites that would get the outcome evaluation. So the 2 sites that have been chosen is, again, a way out, that one that I studied before, but in a different way, looking at individual outcomes. And the other is Plymouth, Massachusetts. So we're using this community level analysis to look at broader impacts. So the outcomes are criminal justice and treatment and substance use indicators. And then we'll look at costs as well to police and partner agencies. So the time period we're looking at is long, from 2005 to 2020. So a big time before and after, speaking of a way out, but we'll do the same with Plymouth. And then we're getting lots of data from human services, public health, state police. So we really look forward to completing this evaluation. It's in progress right now, and sharing the results with what we learned on this one. I'm really excited to be a part of it. Okay, now I'm switching gears to, I was asked to talk about legislation. So states can certainly have deflection programs without legislation, but legislation can legitimize and encourage programs and could offer funding. So there's at least 11 states, and I'm not going to list them all, but Illinois is one of them. And they've passed legislation or developed state policies to support deflection programs. So the Illinois law, and this is a mouthful, the Illinois Community Law Enforcement and First Responder Partnership for Deflection and Substance Use Disorder Treatment Act. So it's a little long, but it was passed in 2018, and there's a reference if you want to see it. The Illinois Act offers definitions, authorizes the use of deflection, makes departments exempt from civil liability. It offers funding and talks about performance measurement. So my agency administers that state funding to programs, and there was an increase of $500,000 to $1 million for this next state fiscal year. And so far we funded 6 programs. Many of them were continued over the years. So here's the links to the reports and also that literature review I talked about. And here's my contact information. So I think I did perfectly 15 minutes, so that's good. I'll stop sharing my screen.
Next, I want to bring up Dr. Brandon Del Pozo, who will talk about aligning public health and public safety through law enforcement provider deflection partnerships. Dr. Del Pozo is an NIH NIDA postdoctoral researcher at Miriam Hospital, the Warren Alpert Medical School of Brown University. Prior to his research career, he served as a police officer for 23 years, 19 years with the New York City Police Department, and 4 as the chief of police of Burlington, Vermont. Dr. Del Pozo, over to you.
Hey, thank you for that introduction. It's great to be a part of this, and I'm excited to have this discussion today with these colleagues to such an engaged audience. So first, just by way of funding, this is funded by the National Institute on Drug Abuse and the National Institute of General Medical Science. I have no conflicts to declare. There's a few quantitative research efforts that we're in the throes of that I wanted to give you a teaser about. It's about the attitudes that police officers have when they engage in discretion, what influences their decisions to make an arrest or not, or refer somebody to treatment. But today, I was asked to do something close to my heart as well, which is take a step back and look at the values and philosophy and public administration aspects of aligning policing and public health using a program like deflection. So, today's subject is the argument I'm going to make is that deflection of people whose police encounters are based on drug use, addiction, mental health crises, or other behavioral health issue improves both individual and public health, advances public safety, promotes racial equity, and is a core role of the police. It's not a substitute for policing. It's not an alternative to policing. Deflection, I'm going to make the case for, is policing. So if you look at some of the older writing on this, the functions of the police in modern society was a monograph that was funded by the National Institutes of Health. So there was a time when the National Institutes of Health was funding police research directly. Egon Bittner is a sociologist who wrote this monograph. And I'd like to take a little bit of it to just kind of frame this. And this is a paragraph. I'll try not to read the whole thing, but I'm always tempted to. Okay, I'll read the whole thing. I know we only have 15 minutes. Despite these widely acknowledged advances, the police continue to project as bad an image today as they have had in the past. In fact, the voices of criticism seem to have increased. The traditional critics have been joined by academic scholars and some highly placed judges. Certain segments of American society, noticeably the ethnic minorities and the young people who've only recently acquired a voice in public debate, express generally hostile attitudes towards the police. At the same time, news about rising crime rates and widely disseminated accounts of public disorder, ranging from peaceful protest to violent rebellion, contribute to the feeling that police are not adequately prepared to face the tasks that confront them. Now, I've been a police officer for 23 years. I have the view that it's a noble and important profession, but this echoes a lot of the sentiments that were voiced by people last summer. This was written by a National Institutes of Health funded researcher 50 years ago. So it just goes to show they're in the middle of a problem that is, except for the archaic phrasing, could have been phrased this way 50 years ago. And the research that brought about this observation, hint to the NIH folks in the room, was NIH funded research. So this is where we are today. This is a recent article in the American Journal of Bioethics by Brian Earp, Jonathan Lewis, and the head of psychiatry at Columbia, Carl Hart. Racial justice requires ending the war on drugs. There's a lot of sound research behind what they're saying, but the harms of criminalization, the harms of over-enforcement, the racial inequities. I'll skip over reading this abstract, but this is a sort of a table setting for where we are today in terms of reflection. And what these authors call for is decriminalization and a very, very wide range of withdrawal of policing from the drug problem. In response to that, my colleagues and I authored a piece that's saying that won't quite solve the problem.
I need to interrupt you for a second. I apologize for doing this. The slides are not advancing.
There we go.
Bring us up to speed. Okay, there we go. Thank you.
So yeah, here we have the research efforts I teased you about. We have today's subject. We have the functions of the police in modern society. That wonderful quote I read you verbatim. And then we have racial justice requires ending the war on drugs. So there's your executive summary. And here we are with the what I authored. So thank you for that. Anyway, so the point is behaviors associated with addiction, whether it's overdose, or whether it's health problems, whether it's domestic discord, homelessness, mental health issues, theft, fraud, burglary, car break-ins, no matter what we do with decriminalizing drugs and having upstream interventions will still require a police response. So there'll still be a need and an appetite for a public health informed response to the overdose epidemic. That's where deflection comes in, right? Now, what I'd like to remind folks is if you go back and you look at the very beginning of our thinking about policing, if you go back, for example, to the city charter of the New York City Police Department, they're not just tasked with enforcing the law or making arrests or bringing cases to judges. They're explicitly tasked with guarding the public health. They're also explicitly tasked, even in terms of roadway safety, with the proper protection of human life and health. So this is not something unprecedented for policing, this idea of deflection. The mandate as far as city charters go is much broader. The other thing I'd like to remind folks when we talk about the alignment of public safety and public health is that city charters and the police mission is about a population level effect. Chiefs of police, mayors, city councils never get up there and say, I want to improve the life of one individual or one city block or one neighborhood. They want to have an effect that takes place over an entire jurisdiction that makes that entire jurisdiction safer. And I'll argue based on the mandate of several city charters in America, healthier as well. So what this comes down to is some research I've done back in my philosophy doctoral training is 3 roles for the police, and deflection fits into this very neatly. 1, protecting and rescuing people in physical danger is a core role of the police. 2, brokering and enforcing the terms of social cooperation in public spaces, whether it's the behavioral disruptions or the health disruptions, for example, that come from substance use. And 3, police do bring people and evidence to the court, but not to the exclusion of these other 2 core roles of policing, right? So the first we see of this, when we look at the history of this, is back in 1995, there's some early research that says we should look at the role that public health has in terms of prevention and talking about prevention when we talk about responses to violence, right? This is sort of the nascent ideas that policing and public health can be aligned. This is some of the earliest research out of the Kennedy School about 25 years ago, right? So more recently, picking up that thread, there's a great paper by Christmas and Srivastava in England. I think they're a few years ahead of us in this research, where they talk about policing and public health approaches. And what they go into, which is an important lesson, is prevention. Prevention is a buzzword for police reform, but there are 3 tiers to prevention: primary, secondary, and tertiary, right? And you have to figure out where deflection fits into the prevention continuum. When you look at primary, it's about restructuring society in a way that stops the addiction, the substance misuse from happening in the first place. That's pretty far upstream for policing, right? But secondary and tertiary prevention meld with deflection very nicely, right? So tertiary prevention is responding to the scene of an overdose or responding to the scene of a burglary or a serious crime, and taking the summary action that stop it from getting worse, administering naloxone, arresting the pattern burglar. Deflection, on the other hand, is in the secondary prevention sphere, is somebody started to misuse a substance, somebody started to become addicted, and instead of sending them down the rabbit hole of arrest, which may result in disruptions that cause overdose, you give them evidence-informed treatment that stops the secondary prevention receptive interventions from becoming ones where you're now engaging in tertiary prevention and sticking naloxone up someone's nose because they've gotten to the stage where they're overdosing, where their addiction is acute, right? So another way of thinking about this too is that within the criminal justice system, this octopus that is the criminal justice system, if you look at this flow chart, these interventions can be considered primary prevention within that system, right? Most of what, and Tisha Wiley, Dr. Wiley talked about this, a lot of what we've been studying are interventions downstream in terms of incarceration, adjudication, release. What deflection does is goes far upstream in the criminal justice system and looks to prevent people from getting engaged in it further away. So in its own unique context, it can be considered a form of primary prevention, right? So what we'll have to do, though, to get to the heart of that and operationalize it is change the metrics and methods of policing to understand where deflection fits in and what type of value it offers, right? So never mind in red that spelling mistake that got past the copywriters. What we're talking about in police reform and aligning it with public health and public safety is what measures are the true endpoints of policing, not how many kilos you've taken off the street, how many guns you've taken off the street, how many people you've arrested, but how many lives are you saving? How much addiction are you ameliorating? How much healthier is the community becoming? You also have to measure, if we're taking a public health approach, the negative effects of your work. Arrests and incarceration are disruptive. They worsen health outcomes. They send people into a revolving door of harms. So your intervention has to measure that as well. Aligning policing and public health using something as deflection has to focus on the true endpoints and has to focus on the negative consequences and seek to lessen them, right? So one of the things you can say, we have 10 standards of care for policing the opioid crisis, is focusing on overdose deaths, right? That's a health outcome that police can intervene in. It's a downstream outcome of addiction, and it's something that deflection should help ameliorate. So when we look at what policing can do to help ameliorate this problem of overdose deaths using deflection, we see extraordinary evidence for medications used to treat opioid use disorder, specifically buprenorphine, methadone, and to some extent also Vivitrol, right? There's an abundance of evidence to show when police, instead of arresting, sending into a trial and incarcerating a person, refer them to medication assisted treatment, medications for opioid use disorder, especially partial agonists and agonists like methadone and buprenorphine, you get better health outcomes for that police intervention, right? So another thing you also get is better public safety. Back in 1991, Ball and Ross did a study where they looked at self-reported days of engaging in crime before and after using methadone. And when you see that people using drugs would report 237.5 days of engaging in crime before being exposed to a methadone treatment. Once they're exposed to methadone treatment and they're in there for years, 1, 2, 3, 4, 5, 6 years, they're reporting being engaged in much less crime. Same thing for buprenorphine. Liz Evans et al. Did a study recently that shows rearrest after being released from prison. When you're on buprenorphine, recidivism and rearrest go down. So if we're looking at what deflection offers in terms of public health and an evidence base, it's shunting people into an intervention, medications for opioid use disorder that reduce fatal overdose, reduce non-fatal overdose, reduce relapse, reduce illicit opioid use, and reduce crime and reduce rearrest. That's where deflection aligns with public health and public safety, right? So another thing that you have to think about in terms of deflection and use of discretion is what harms can you avoid? And an example I'll give here before we wrap up is arresting people for possessing unprescribed buprenorphine. Unprescribed buprenorphine, it's Suboxone, is overwhelmingly used to treat people's addiction, a form of self-treatment, a form of self-medication, a form of making it through a risky period safely. And one of the things we found is that people report overdosing less often when they're taking illegal buprenorphine. So one of the things I felt back when I was the chief of police, that it was incumbent on police officers to not arrest people for unprescribed buprenorphine. It was a way, going back to that chart, of reducing a negative effect of enforcement, right? Instead of arresting people and putting them in the justice system for an unprescribed addiction medication, let them keep it because evidence says it's associated with reductions in overdose. And what does a misdemeanor arrest for Suboxone really get you anyway, right? Now in Vermont and Rhode Island, they've actually legalized the unprescribed possession of buprenorphine, taking the discretionary question out of the hands of the police, but it's in acknowledge of the type of evidence that said when police use their discretion not to arrest for this charge, you get better health outcomes. So I'll tease us at the conclusion of this with some of the, go back into the quantitative stuff. I gave you sort of like a moral and political and philosophical case for how policing, public health align with discretion, align with prevention, primary prevention, secondary, tertiary, all of that. Here's what some cops think about it. Number one, in a study we have that's under review, most cops perceive that they have control over whether they make an arrest or not. These are not deflection agencies. These are non-deflection agencies in this data. 35% perceive total control over whether they make an arrest for a drug-related misdemeanor. 70% perceive at least some control, right? They're inclined, in most cases, except when it comes to syringes, to not make arrests for naloxone. Well, naloxone's lawful, so not confiscate naloxone. Not arrest for syringe possession, not arrest for drug possession, to refer to treatment. There is this impetus there to do that. But I'll direct your attention to the bottom table, which is 3/4 of the participants in this study agreed that their supervisors would approve of deflection, that their coworkers would approve of deflection, that their friends and neighbors would approve of deflection, that deflection would reduce future arrests, and that deflection increase trust in the police. So with this data, this is 3 states, about 25 agencies, about 173 participants show even before you implement discretion, the seeds for it are there. Cops believe they have the discretion already not to arrest. They're inclined not to arrest. They believe everyone around them would approve of them doing it. And it's not in this chart, but when you look at the data, the cops that strongly believe that it works, that it reduces future arrests, and that that their supervisors approve of it and their colleagues approve of it, are the same officers who in practice are already giving people warnings rather than making arrests. So I think there's a good empirical basis for widespread implementation of deflection. So that said, this is some of the team and colleagues that underlied the research that you just saw. I'd like to thank them. Sorry that the slides didn't advance in the beginning. I'm still self-conscious about that, but I hope that you absorbed what I was saying anyway, and I'd be happy to answer a bunch of questions later on in the discussion. Thank you.
Now let's turn to another colleague, Dr. Amy Watson, who will speak on findings about various from research on deflection diversion efforts in mental health and crisis intervention. Dr. Watson is a professor of social work in the Helen Bader School of Social Welfare at the University of Wisconsin-Milwaukee. She has worked extensively on issues involving persons with serious mental illness who come into contact with the criminal justice system. Dr. Watson, right before you start, just to remind our audience, again, we want your engagement. You're doing a great job. Please put comments in the Q&A at the bottom middle of your screen. We're not using the chat box. If you're wondering why that's not working, go to Q&A. And then to all our presenters, please make sure you're checking the Q&A. There are questions coming in for all of you. Thank you again, Dr. Del Pozo, and Dr. Watson, over to you.
Okay. All right. So hopefully my slide did advance. So I'm going to talk briefly. I have about 15 minutes to cover everything mental health crisis response. So it's a lot to cover. I will try to hit some points, but just briefly to get started, what we know about police contact with people with mental illnesses. Some of our best estimates looking across studies are that 6% of all police contacts with the public involve people with serious mental illnesses. If you broaden the definition of mental illness, obviously it would be higher. Additionally, what we've heard anecdotally is as a result of the COVID-19 pandemic, that those numbers are increasing as well. I have to also indicate that not all of those contacts are mental health crises situations, but certainly some of them are. We also have evidence that almost a third of people with serious mental illnesses in the US have police involved in their pathway to care. Numbers are likely higher in urban public mental health settings. As you know, and we certainly know that there's race disparities in terms of how people enter mental health services, with people from communities of color being more likely to come in through more coercive channels. The best data that we have on individuals fatally shot by police suggests that at least 1 in 4 had a mental illness. And there's evidence that among all people that are fatally shot by police, those with mental illness are less likely to have had a firearm. They're also more likely to have been killed in their own home. We know that people with mental illnesses are overrepresented in the jails and prisons in the US, with over 1 million arrests of people every year. And once they enter the system, they stay longer. So we see this overrepresentation in incarceration settings. And it's in part due to people having a higher rate of coming into the system, but once they enter the system, they tend to stay longer. So they serve more time pre-trial in jail. They serve more of their jail and prison sentences. And if they're on community supervision, they're more likely to have that revoked for technical violations. So once they get in the system, it's a lot harder for them to actually exit the system. When we're looking at mental health crisis diversion and deflection models, particularly at that very front end, we tend to see these models kind of fall into 3 categories. One is the crisis intervention team model, which has been around since 1988. What we're seeing actually grow in popularity in the US right now is the co-responder model, which typically puts a clinician along with an officer to respond to mental health crisis events. And then we're also seeing community responder models starting to develop across the country, the most well-known one being the CAHOOTS model. So I'll talk about each and what we know in terms of the research. Also, this is just a graphic from the Vera Institute of Justice. They've done quite a bit of work in this area, just kind of thinking about law enforcement involvement in mental health crisis response, with some of the models being completely police-based. Sometimes we think about the CIT model, which is really a partnership model to develop crisis systems and reduce law enforcement involvement. But a key component of it is that training for specialist officers so that they're prepared to respond safely and effectively. And then we have the police-based co-response, and then moving all the way over to the end of the continuum with these community response models that provide response without police unless there's a specific issue that requires police assistance. So starting with the crisis intervention team model, really CIT, while most people think of CIT as a training model, it really is a partnership model that brings together other first responder agencies, community providers, advocates, family members, and people with lived experience of mental illness. And that's really what the team means in the CIT acronym. It's those partnerships. Another component of the model is a single point of entry into emergency psychiatric services. So if officers are responding to a mental health crisis, they have a pre-identified place where they can connect people to care as quickly as possible and move them away from the criminal legal system and into the mental health system. Of course, there's the 40-hour CIT training for specialist officers that really it's provided by those partnerships. So bringing in your community providers as content experts to provide some of the training, bringing in family members and people with lived experience to interact with the officers going through the training. And again, it really is a larger program model designed to develop a crisis system that reduces involvement of police, but then make sure that police are prepared to respond with needed. And full disclosure, I am currently the the president of the board of directors of CIT International. And I just put up the cover of a best practice guide that is available on our website. You can download it for free, but it really goes through sort of the larger program model for CIT if people are interested. In terms of the research on CIT, there is a growing body of research looking at CIT, and we have pretty strong evidence that CIT training can improve officers' knowledge, their attitudes, and confidence in responding safely to mental health crisis calls. We also have other studies that have looked at CIT implementation, as well as studies that have compared CIT to non-CIT officers. And we have good evidence from several different types of studies that suggest that CIT can increase linkages to services for people with mental illnesses. In terms of use of force outcomes, some studies have found no impact on use of force. Other studies have found some impact, a small effect. One of the studies that I did in Chicago, we found that CIT training reduced the use of force with more resistant subjects. So, we can't say with strong confidence because we don't have too many studies that really can support that finding, but there are some signals that it may reduce force. Similarly, findings related to diversion from arrest vary, with some studies finding no effect, with other studies finding a reduction of arrests of people with mental illness. Again, some of that has to do with context as well, that the studies are done, methodology. We need more research to really determine if it is effective for reducing arrests. The CIT model, according to the original models, suggests that it's for patrol officers that volunteer and are vetted, that go through the training and become specialists. Although many agencies are now looking to have all of their officers CIT trained. Some work that was led by my colleague, Michael Compton, did find that the effects of CIT on knowledge, attitudes, and confidence, as well as linkages to CARE's so-called outcomes, are strongest when CIT follows the volunteer specialist model. This is just from a recent article that was published in Policing from a study that I led in Chicago, looking at police response to mental health calls and their CIT program. And this study did support the finding that CIT response does actually increase the likelihood of people being linked to mental health services or transported to care. We also found that calls that were pre-identified at the dispatch level as mental health related were more likely to be resolved with a linkage to care, which gives some signal that, again, it could be because those calls were different from the beginning, but it also gives some signal that there could be importance to making sure that our call takers and dispatchers receive some training to be able to identify these calls and provide information to officers. So I'm going to move on to co-responder teams. This is a model that's been very popular in the UK, Australia, and Canada, and is now gaining popularity here in the US. And really, these teams are pairing of clinicians and officers to provide response to mental health crisis events in the community. And their goals are to reduce arrests, increase safety. They also have the goals of reducing emergency department transports and hospitalizations and increasing linkages to care. Looking at the literature on these, what we find is that there's a lot of variation in terms of how co-responder teams are implemented. In some communities, the clinician rides along with the police officer to respond to crisis events. In other communities, they actually arrive separately, but then respond on scene together. And still in other communities, the officer is the only one that responds on scene, and the clinician provides telephone or iPad type of support to the officer. There's also variation in terms of whether they respond to hot calls, if they're dispatched by the 911 center as the first responder to the calls, or if there's secondary response where an initial officer responds and identifies it as appropriate for the co-responder team, and then the co-responder team comes out. Regardless of which model they follow for response, in many communities, these teams are also providing some follow-up to people that have had crisis events. Oftentimes, these teams don't operate 24/7 due to capacity issues, but they typically try to target times with higher frequency of mental health crisis calls. The body of research on co-responder teams is growing pretty rapidly. There's been 2 systematic reviews. Most of the research is either descriptive or quasi-experimental, but across the board, generally what we're finding is that these are models that are generally acceptable to stakeholders, and that they can improve collaboration between police and mental health. There is quantitative data that suggests that implementing these teams can reduce emergency department transports, but increase admissions for people who are transported. So if it's just an officer arriving on scene, they may be more likely to make a transport because they don't feel like they can make a full clinical assessment. But when the clinician is also on scene, that allows for that assessment to happen without doing unnecessary transports. There's also some data suggesting that they can reduce repeat calls for services by better connecting people to care in the community. And some qualitative studies have also found that people with mental illness that have had response and family members prefer co-responder teams over a police-only response. In a couple of those studies, there was some mention with something suggesting that particularly people with mental illness that have had a crisis, they would really prefer no police at all. But they absolutely prefer having a co-responder team to a police-only response. So the third model that I'm going to cover is 911 dispatch non-law enforcement alternatives, which are also referred to sometimes as community responder teams. And I want to make that distinction of 911 dispatch because many communities have had some availability of mobile crisis teams on the mobile health side, for quite some time, although certainly places that I've lived, that capacity is pretty low. So trying to get a mobile crisis team can sometimes take hours, which means that if it truly is a crisis situation, it reverts back to police. What we're seeing now is the development of teams that can be dispatched by the 911 system and respond to crisis events in the community without law enforcement officers. And of course, the most well-known one that is the CAHOOTS model. And I always I spell out the acronym on the slide because I can never remember it otherwise. It's Crisis Assistance Helping Out on the Streets. And it's actually been in operation in Eugene, Oregon since the late 1980s. So it's been around as long as CIT. It's just now really getting a lot of attention. And what it represents is a partnership between a community mental health agency and the Eugene Police Department. And it's paid for by the Eugene Police Department. So it's coming out of the law enforcement budget. And what it is they're teams, two-person teams that are typically a bachelor's level crisis worker and then a medic, which could be a nurse or an EMT. And when they do presentations, I've been on several panels with them, they really do try to prioritize when they're hiring their team members, people that have some type of lived experience that's relevant to the populations that they're responding to. So they don't specifically hire certified peer providers necessarily, but they do try to prioritize that. They are integrated into Eugene's emergency communication system. So they are dispatched at that level and they wear police radios so that when they go out, they are able to ask for police assistance if they need it, and police also know where they're at. The services that they provide are voluntary. So if they're responding to someone who's in a more acute crisis that may need an involuntary transport, then they would have to call in another team. There's not any peer-reviewed research that I have found on this model yet. However, the data that they have suggests that they are able to take on a large number of calls that would have otherwise gone to police. In 2019, it was about 24,000 calls that they responded to, and only 311 of those calls did they end up having to ask for police backup. They also have the availability that police officers can identify situations and ask for CAHOOTS to come out to respond to someone and address somebody's needs in the community. So they certainly do that. And of course, they have the ability to ask for police assist as well. And while we don't have a ton of data or research on this, I think the one thing that it does show is that it is possible to triage calls coming in and identify calls and provide non-law enforcement response to at least a subset of these calls that are coming in to emergency communication centers. So just kind of looking overall, there's a lot of variation in the models that are out there right now for that sort of front end deflection in terms of how they're accessed and who responds. We're seeing a lot of different makeup of different teams that are coming online as different communities try to figure out, okay, so we have police, what else do we need as options, particularly as the 988 crisis line is coming and we're seeing additional funding. The other places where things vary in terms of whether if a transport needs to occur, if it occurs via police, a patrol car, an ambulance, a van, where these services are housed also varies quite a bit as well. Certainly CIT, those officers are housed in a police agency. Co-responder teams typically are housed out of a law enforcement agency as well. But some of these non-law enforcement models are being hosted in fire and EMS agencies or mental health agencies as well. The other variation is who pays. Many co-responder models, you have law enforcement agencies that are paying for the clinicians, but in other communities, the mental health system is actually funding the clinicians. And something that's interesting, I'm in Milwaukee now, and we have what's called CART teams that go out and do assessments, and it's an officer and a clinician. And our county behavioral health agency actually funds the clinicians, and when they're starting a new team for the first couple of years, they fund the officers as well to provide that service. So there's variation there. I was also asked to talk briefly about screening tools for law enforcement, and I'll do this quickly. We're starting to see tools become available. They have somewhat different goals. There's one tool that's available that was developed by InterRAI. It's a brief mental health screener assessment form. It was developed by a group, actually some folks in Canada. And they had a large database on people that were admitted for psychiatric hospitalization, and they use that to sort of identify the domains of their screener tool. And really, the tool is in clinical language, and so officers are trained to use it, and in the process, they also learn the language that they need to communicate with providers when they're transferring custody of someone. There's an app that goes with it so that if officers use the screener, that's stored. There's some algorithms that kind of give the officer some information on risks. It also, if someone's having repeated contacts and an officer comes in contact with them again, that officer has access to the data from previous contacts, and they can see if there's some patterns going. So there's a lot of work going on around that. There's also a tool that the NYU Law School Criminal Justice Lab has developed. There's information on their webpage, but the goal of that one is really to help officers identify people who may be eligible for deflection and diversion options. And it's a 10-item screener. It has 3 subscales to identify people who may have a mental illness, suicidality, or substance use disorders. And they have validated the tool by screening people that were booked into, I think it was 3 different jails. And they were able to show that it was pretty accurate in terms of identifying people, but also 48% of the people that they screened positive to one or a combination of these factors that might make them eligible for diversion or deflection. So here they screened everybody. The InterRA screener is really for officers that have the perception that the person has a behavioral health problem. That's when they would use it. So there's some different uses of these tools. So we're starting to see more and more tools available at that level. So that was all I have, just to very quickly cover sort of the universe of what's going on. There's a lot of activity on the mental health crisis side, and there's a lot of resources out there as well.
Thank you, Dr. Watson. Appreciate the presentation. And for everybody, you see the mental health versus the SUD side of deflection. They're very different. They don't always interact with each other. And yet we know that people in communities need access to both, but you do see there are different streams running in deflection. Okay, now we want to get to, as I've said all along, audience engagement and participation. So I'm going to do a few things. First, I'm going to remind you, please go to the Q&A, bottom middle of your screen, start getting your questions in. Presenters, please look at Q&A. You've been doing a good job of answering, but keep that up because there are questions for each of you there. What we want to do now is get to the audience interaction part. I said up front, I was just going to do a quick opening to get us underway, and then I would return to introduce my colleague and a few other parts of JCOIN. While I'm doing that, this is intentional. Please go ahead and use the Q&A and start putting your questions in there if we've not heard from you already, or maybe you have a new one. So we heard right up front from Dr. Tisha Wiley, who is the NIDA JCOIN lead. And I also want to, as I said up front, acknowledge Jessica Halsey, who will come on video now. She is the founder of APF and the DSEC, Dissemination Stakeholder Engagement Core co-lead, which is all part of the Coordination and Translation Center run by Dr. Faye Taxman out of George Mason University. And the important point of all this within JCOIN is CTC handles lots of the different arms and elements that make JCOIN go and make it function under Dr. Taxman's leadership. And the DSEC DSEC really is about outreach and engagement with stakeholders, practitioners in the field, and experts. So I like to do that usually kind of in the body while everybody's around. So you hear the complexity and the range of people and organizations that are involved to make JCOIN, the CTC, and DSEC, which work together, obviously in partnership with each other as elements of JCOIN. With that said, then, very quickly, just hitting a lot of the questions. Yes, the slides will be available. Many of you have asked. Yes, they will be available, so you will get those. And then just one opening comment, and that's this, and then Jessica, you and I can get to the questions. You've heard us use the word deflection, and then we see diversion. Just keep in mind, deflection is a word that is centered in centers its responses in the community. Diversion centers its responses in the justice system. So as you're thinking about this, put your mindset into community-based responses, community-led, grounded, founded responses. That's deflection. That's why you don't hear us using the word diversion. We're not in a justice system control mechanism. We're in a community-based control, if you will, and that's not even the right word for community, hence why the word deflection. Okay, with that said, Jessica, yep, good. You're on screen. Let's go ahead and get started. And just for our panelists, remember you've got comments in there also, if you can go ahead and keep answering those. Jessica, I'm glad to throw it over to you as the DSEC co-lead and get going on something. If you saw something in the chat box or that you'd like to start with, or another question.
Sure, thanks, Jack. We have a couple of questions in Q&A. I think one from Dr. Taxman for Brandon to address and sort of speak to the fentanyl issues, sort of clarify that in context of all the work that you're doing in your research.
Hey, thank you. Yeah, I mean, fentanyl, as many know, is the synthetic opioid that's responsible for the vast majority of the 94,000 overdose deaths we had in 2020. And if we're talking about policing's role as protecting people, as preventing death and injury rather than enforcing the law, then fentanyl is one of the key targets of intervention for the police. And it's not going to happen by the supply side, right? We've had no successful supply side interventions against fentanyl. In fact, it's because it's so much more potent, basically any given quantity is much more profitable, much more easy to produce. And it's all synthetic. You don't grow poppies to produce fentanyl like you grow poppies to produce heroin. And I bring that up to say that on the policing side, as almost impossible as it is to stop the production of poppies being converted into heroin being brought into the US, producing fentanyl in a factory right over the border with precursor chemicals is doubly difficult to stop. So to alleviate this very potent threat to life, it's even more incumbent on the police to engage in interventions that get people out of the throes of substance use and addiction. And deflection is even more important for this response. Also, police need to have a discretionary attitude towards things like fentanyl test strips. It's a strip that, like a pregnancy tester, gives you a very quick indication when you expose it to the substance of whether it contains fentanyl or not. It looks, it's that simple. In some cases, that's considered drug paraphernalia. In other cases, police confiscate it. In some states, I urge police officers to use their discretion in confiscating or charging for fentanyl test strips. That is something that empowers people to know what's in their drugs so they can use the drugs more safely, because the goal is to keep them alive. The goal of policing is to prevent death. I guess so. The last thing I'll say in that regard is the market, the illegal market, which is the illegal fentanyl market, is an opaque market. There's not like a label on the drugs. And what a fentanyl test strip does is allow people to know what's in the drugs despite there not being an ingredient label on them. And I think it's really incumbent on police to deflect into treatment and not confiscate or arrest for test strips. So thank you.
Thank you so much. Jack, was there a question you had teed up?
Sure, absolutely. And this is coming from the participants, from the audience, not only to the times in which we live, but certainly for all of us who work at the intersection of justice and health, the issue of race and equity and drug use and drug arrests was mentioned by several people in the Q&A section. So wondering if any of the panelists could speak to when we are looking at deflection initiatives, what do we see or know about this? And I know the field is very young, but what do we see or know about this intersection of how deflection might or might not be impacting race and equity, both in its application as well as stopping the justice system inequity that occurs as a result of arrest? So kind of combining a few things that came in very complex in the Q&A. You don't have to give a final answer. Just speak to what you know. It's okay. We know this is underway. And I saw some of you respond. It's okay. So yes.
Well, Jack, one of the things I brought up in the question was that we had covered in our survey is the proportion of people who are deflected by race, ethnicity. And the numbers, at least from what we found, are much, they're certainly, it's the Black population that's deflected is proportionate to the total Black population. The follow-up question is a really good one, and I have to check the survey for that. So, I mean, at least there's some preliminary indication there that, we're possibly addressing some of these issues in a way that could be quantified a little bit. But I do want to go back and look at exactly how we address that specific point in the survey.
Very good. Thank you.
Yeah,
Dr. Del Pozo. Oh yeah, go ahead. I saw you
please.
unmuted. Yep.
Yeah, no, what I was going to say is that, the equity, the racial equity of policing is front and center, and for us not to speak directly about it here is a disservice to police reform. That said, right, so buprenorphine is one of the most effective interventions for overdose and addiction, and it is much less available per capita in communities of color. In fact, there's a study came out, I believe out of Rand, that showed that as new doctors agree to prescribe buprenorphine, it almost always or overwhelmingly accrues to white and affluent zip codes rather than zip codes of color and poorer zip codes. So I think the unfortunate, and there's less uptake of this highly effective medication in Black communities. So we don't want there to be a situation where the default avenue for treatment in communities of color is arrest or police contact, right? It should be needing help, going to harm reduction, going to a physician, going to a clinic and getting inducted. But because the opportunities are just fewer in terms of availability, I think that police, if we're taking it, some people might say this is not going to happen, they're not in the right headspace, but police can set the norms and take the lead in saying, we know there are limited resources out there in the community, but when a person who uses drugs comes in contact with the police, we are going to refer you to the most effective interventions out there. That's medication, right? Setting that norm, I think, lays the bedrock for expanding these services community-wide. And right now, there's less access to the most effective medications in Black communities.
Thank you. Jessica, over to you.
I think we're sort of running out of clock here. There was a really interesting question that came in through the chat, though, on if there's been application of deflection models in sort of the EMS lane, and also a question about whether or not there's been coordination with hospital systems to sort of combine those resources and referrals to work together on the community level. So I didn't know if any of our speakers and presenters wanted to speak to either the EMS or the hospital piece.
I think there was a question about even CIT training and EMS providers. And actually the Chancellor Fire Department in Arizona is doing CIT training for their EMS personnel. And in many communities, their EMS personnel actually attend the CIT trainings that are held. And I think we're starting to see that more broadly if we're looking at some of these non-law enforcement models as well. Many of them are including EMS personnel. So I think we're seeing more of that coming online. And I think that's going to be really important because many of these things are health situations. And if they don't need law enforcement response, then if we can support the EMS system in providing response, I think, then we're not even having any contact with the criminal legal system.
Well, thank you. Was there any other quick response any of the panelists wanted to make to Jessica's question?
There's low barrier induction to buprenorphine in the emergency department in Burlington, Vermont, and the police were able to bring patients directly to the ED to get inducted. Did the ED always appreciate just being the dumping ground for that? Did they prefer there were other ways in? Yes, but they didn't turn anyone away. And so that speaks to that possibility.
Good, thank you. Well, it is the top of the hour, so I do want to bring us to a close. First of all, very quickly, thank you all for being here today on the webinar. Very much appreciated. You'll get a link to this as well as all the slides, as I said. So please go ahead and share this. Share this with your colleagues who are not able to be here today, but would be interested in this. Thank you, of course, to the leadership of NIH, NIDA, Dr. Wiley, JCOIN, Dr. Wiley, CTC, Dr. Faye Taxman at George Mason, DSEC, Jessica and her team at APF, and the TASK team. And with that said, thank you very much. Have a wonderful rest of your day. It's been a pleasure to be with you today. Bye-bye.